14-year-old patient reported to the hospital today with acute respiratory distress. The patient has a past medical history of cystic fibrosis, which they've had since birth. His father passed of cystic fibrosis 4 years ago, and his mother is a heterozygous carrier. The patient has also been diagnosed with ADHD since age 8. 2 weeks ago, the patient had experienced a cold with cough, congestion, and rhinorrhea, and 1 week ago presented to their pediatrician for a treatment of the cold. The pediatrician then prescribed ciprofloxacin for the patient, but was minimally effective and was then sent over to the pediatric ward from the primary care provider. The patient has presented with cough and congestion, a fever, worsening fatigue, and 4 to 5 loose stools per day. They also have dried mucus in their nares, rhonchi in the upper lobes of their lungs, as well as bronchostasis consistent with cystic fibrosis per chest x-ray. 6 months prior to admission, the patient had a culture and sensitivity positive for Pseudomonas aeruginosa. Their current medication and therapy regimen is as follows: fluticasone 110 micrograms, 2 puffs BID, prednisone 10 milligrams QD, ciprofloxacin 500 milligrams BID, which was started almost a week ago by the primary care, azithromycin 250 milligrams Monday, Wednesday, and Friday, Dornase alpha 2.5 milligrams via the nebulizer QD, which actually hasn't been filled in over 30 days, pancrease 10,500 units before meals, Metadate CD 40 milligrams QD, and chest physiotherapy BID to TAD, and also a children's multivitamin once daily. Inpatient, the patient has been getting ceftriaxone 1,000 milligrams IV every 24 hours, tobramycin 380 milligrams IV every 24 hours, and acetaminophen 325 milligrams every 4 hours is needed for a fever. Our patient appears to be presenting with an acute exacerbation of their cystic fibrosis. This may be stemming from the lack of compliance with the patient's Dornase alpha, which should be addressed with the mother in an attempt to limit these exacerbations. Secondly, a Pseudomonas infection may be manifesting from the lack of controlled treatment of their cystic fibrosis. I would like to recommend the patient discontinue ceftriaxone therapy as it does not have Pseudomonas coverage. It is recommended that the patient have 2 Pseudomonas medications to cover resistance and work in a synergistic way. Since the patient is already being given tobramycin 380 milligrams IV every 24 hours, I would also like to recommend the initiation of ceftazidime 1900 milligrams IV every 8 hours in intermittent infusions over 15 to 30 minutes. A couple things to look for with this new therapy would be to monitor renal function and anaphylactic reactions. Finally, I would like to manage this patient with oxygen while they are still in an inpatient setting. Thank you.